one of them said in the My Nursing Lab, this stimulates the central nervous system.
Okay.
So in the post-test question, we click, this stimulates the central nervous system. We got it wrong. So I mean, I like cut and paste.
Looks like this is recording. Also under recordings, finally got that lecture, that 3-hour mosquito droning in your ear lecture uploaded. There were multiple steps to get this up there. So I'll record today's lecture and try and get that also to TigerNet on 324. Just FYI, so you can find that.
Just have to put in a plug. Julia and my kids are notable on our video, so if you don't like, just you can even turn off the volume and just watch her.
Okay, so I don't want to turn everything off, so you're going to have to look at this. It'll go blank and it'll look a couple minutes. This is class. Another item, I'm appreciating that I'm getting some contacts for students to complete their health stream training up in Huron. October 28th is a Friday, a week from now. And a number of you have contacted me for attending health stream training. Let's see a show of hands. Who's all going to go? There should be like 7 or 8 of you, right? 7, yeah. Denise Brock is going to be your contact person when you get to Huron. I'm not going to be in the building, so Denise will take care of you. She's a very nice lady. They are, yeah?
Is it possible that I can go tomorrow after the seminar?
I would have to try and contact Denise because she's not always like, she's got multiple jobs and she wants to take care of you. I also think they also want to do a little recruiting while you're up there, so don't be surprised if they say, look at all these job openings. Why don't you come and apply? So I've sent requests for October 28th, and I've also sent requests for November 1st because there's a number of you who have contacted me for November 1st. So I've started a list. I'm checking it twice. There's a few open names yet, but you gotta get that health stream training done before you can do clinicals at HRM.
Is there still an opening on this one?
I'd have to look.
And like, I don't think I work. There's gonna be some.
Oh. They can take like 4 people at a time at health stream training. Maybe a little bit limited that they can only take 4, but it is what it is. So we gotta go with it. So I'll let you two talk it over. There you go. Okay. We are gonna get your ATI books out to Harvard Health Parker. And it might seem like we're starting a little bit backwards, but we're actually going to start with chapter 47, which is on page 375 of your ATI books. And that chapter 47 is about the mycobacterials and fungals. That's what we're going to focus on for Unit 5. Unit 5, guys. Okay. I'm going to pass out these handouts. These are available from the CDC, Center for Disease Control and Prevention. The CDC is big, especially when it comes to tuberculosis. So there are 3 handouts. I'm going to start these in the front, and they should make their way all the way around the room. But 3 handouts. Also going to send the paper punch if you're a fan of that. So please take one of each of these handouts that I'm passing back. Thank you. Yep. Tomorrow when Joe Ober comes to talk at seminar tomorrow, one of these please. Take one and pass it along. When Joe comes to talk about precautions tomorrow, she'll probably talk a little bit about precautions that have to be utilized for tuberculosis or anybody who's suspected of having tuberculosis. Having a contagious disease in a hospital setting is almost the reverse of our judicial system. In our judicial system, you have to be proven guilty before you can be have a sentence imposed upon you. But in a hospital setting, if they even suspect that you might have C. diff or tuberculosis, they will put you on a higher level of precautions until you are proven to be free of that disease process. That makes sense. It's kind of like, it's a knee-jerk, to me it's kind of a knee-jerk reaction. We overreact, but it's to protect ourselves, it's to protect other clients, other patients in that healthcare facility, and that's important. So when Joe Ober talks about precautions tomorrow, take good notes. Remember, when you go to the healthcare facility, they usually have good signs, good policies that help support that. But it is important. A couple of years ago, I visited with one of our graduates who had taken the NCLEX, and she said, like, there were a lot of questions on the NCLEX about what level of precaution certain patients are taking. When you go into the hospital setting and take care of any patient, what kind of precautions are you going to take? Everybody gets standard precautions. So, good hand washing, make sure that we're safe, that we don't take our pathogens from patient to patient, right? So good hand washing is going to be big. Okay, so have the handouts made their way all the way around the room. Everybody's got 3 handouts. Yep. Cool, very good. Okay, so we got our handouts. And I'm going to be looking, first of all, at the ATI pharmacology book, page 375. Take advantage of found today. So chapter 47 is about this Mycobacterium tuberculosis. You kind of wonder why they put Mycobacterium tuberculosis along with the fungal type thing. Mycobacterium is actually very much like a fungal. It's a little bit different than fungi, but it is considered to be Mycobacterium. If you took your microbiology, you know about all those different pathogens. Okay, everybody took micro. Okay, good. The Mycobacterium tuberculosis, because it is slow growing and it's difficult for the medications to actually treat it, a lot of the times the treatment is very prolonged. If you think back to the infectious disease part of our pharmacology, when we put patients on antibiotics, sometimes those antibiotics are a course of 3 days. Sometimes they're a course of 10 days. Sometimes it's 2 weeks. But for Mycobacterium tuberculosis, it's like months to years. So any kind of fungal infection usually is longer than 2 weeks. It's usually months. For some tuberculosis, it's actually years. So if You want to highlight that necessitates long-term treatment. That's important. As is, long-term in treatment increases the risk for toxicity, meaning it's hard on the kidneys, hard on the liver. The long-term treatment is actually the cause for poor client adherence. Because a patient has to take these medications for months, up to a year, patients aren't always adherent to the prescribed, to the prescription. So that's a lot of times why the medications that we're giving that patient do not work well, because they kind of forget. So you can see down at the bottom of one of your handouts, a couple of your handouts actually, this poor client adherence actually goes along with, because this is like, it's a very important disease to treat. You will see some patients have what they call DOT, Department of Transportation. It's direct observation therapy. So it's DOT. So DOT may actually be required. It's like, it's so important that it is actually required. Direct observation therapy is when the patient comes into you, you give that patient the medication, and you have to kind of engage them in a little conversation, make sure that they've taken their medication, and then you chart it, because it's like a state law, it's a federal law. This DOT, direct observation therapy, is actually something that you do. When I was working over at SDSU and I got to work in the student health services for a short period of time, we had an international student who had tuberculosis, and he had failed tuberculosis treatment therapy because he wasn't taking his medication. So it was actually part of our job, this DOT. This patient would come to us. He was supposed to come every day, but of course he did not. He was supposed to come every day. We would dispense his medication, stand there and watch him take those medications, and then chart that he had actually taken. But when you look at that, when I looked at his chart, there were like gaps, days that, again, did not come. So you kind of wonder if that therapy, that medication treatment, that prescription was actually going to be effective for him. But it was DOT. The first time I actually experienced that was a little bit like, what? Can't you take your meds? You gotta come here, but it is what it is. Okay, the other concern about tuberculosis is this development of medication-resistant strains. So TB is actually just like every other multi-drug resistant organism. It's becoming resistant, and that's a concern. So you will see patients who have TB, they don't get just one medication. They quite often will get up to 4 different medications at a time. So knowing that treatment of tuberculosis requires the use of at least 2 medications, like I said, sometimes you will see 4. So as a result of that, knowing that your patient may have at least 2 up to 4 medications, become familiar with the prototypes of the antimicrobials. So isoniazid is under our select prototype medications. I'm afraid I'm going to spit out my gum. Try not to get rid of it. So highlight your isoniazid. Your other medications under the antimicrobials, the pyrazinamide, the ethambutol, and the rifampicin. So the next thing I want you to kind of highlight on the page, top of page 375 over on the right-hand side is active tuberculosis is several antimycobacterial medications are used to treat a client who has active tuberculosis in order to decrease medication resistance. That is important. So knowing that we're giving these powerful antimycobacterial medications, they've got complications which are really hard on patients, which probably leads to why patients don't want to take them. But some of the complications, peripheral neuropathy is under complications. Peripheral neuropathy is like numbness, tingling. Sometimes they call it paresthesia. It means like you can't, your sensation is altered, especially on your extremities. So peripheral neuropathy, tingling, numbness, burning, pain resulting from deficiency of vitamin B6. So don't be surprised if when your patients are on some of these medications, especially this INH isoniazid, they're taking pyridoxine, vitamin B6. No, that's a very normal thing to be supplementing your patients with, vitamin B6. But know the generic name for vitamin B6. The other complication that we have to be concerned about is hepatotoxicity. It's the liver. Save the liver. So as a nurse, we have to do lots of patient teaching. And it's kind of cool on these handouts from the CDC. It says, watch for things like cola-colored urine, light-colored stool, nausea, vomiting, things that indicate hepatotoxicity. Your patients will probably have to have at least a baseline, if not monthly, liver function tests. And that's under nursing considerations for complications. Under the hepatotoxicity, monitor liver function tests quite often, monthly. It has to be done at least monthly until you know that things are going to be pretty stable for that patient. The next item right underneath that, along with monitor liver function tests, teach your patient, tell them to avoid alcohol. Because alcohol can be hard on the liver. Other complications, especially for the INH, hyperglycemia, decreased glucose control. So if you've got a diabetic patient who is also positive for tuberculosis, they might have some real challenges maintaining a stable blood sugar level. And as nurses, you know the best way to monitor your patient's long-term glucose control is what lab test? Hemoglobin A1C. Awesome. Very good. What else did I want to tell you before we turn the page? Tough medications, or tough education system. INH, this isoniazid, actually has a black box warning because it can cause fatal liver failure. So take care of your liver. Ethambutol, this ethambutol says it's bacteriostatic only to tuberculosis. Ethambutol actually has kind of a crazy side effect. It's called optic neuritis. This is not in your, it's not in your ATI, but ethambutol could cause optic neuritis, meaning it can alter the way a person perceives colors like red and green. It's kind of like it changes their color perception. Optic neuritis. Okay, I'm turning my page to 376. Under nursing medications for some of these antimycobacterials, as good nurses, we're going to tell them, instruct your clients to complete the prescribed course of antimicrobial therapy even though manifestations can resolve before the full course is completed. That's the last little bullet under nursing administration. But again, we know that can be a huge challenge because patients' non-compliance, not taking their meds, is the primary reason why this therapy is not successful. Okay, we're going to go next to the broad spectrum antimicrobial called rifampin. When you get your Unit 5 exam test, it asks you which medications can you identify. This sounds like a great SAT question. You might have to pick out medication used to treat tuberculosis. Okay, so rifampin, complications, discoloration of body fluids. There's a number of medications that can cause discoloration of body fluids. So inform our clients of expected orange color of urine, saliva, sweat, and tears. So that means even your wife beater white t-shirt, right? Is that what they still call them, wife beater white t-shirt? They can have like huge underarm stains. White undergarments can become discolored with like rust-colored stains. Contact will become stained. So prepare your client for that. They may have to wear glasses for a year so that they don't stain their contacts. But that is kind of one of those expected type things. So make some alterations in how they live life. So one little pitch about tuberculosis. Tuberculosis is especially prevalent in crowded environments. So like jails, immigrant camps, what else? Homeless type shelters. You'll see maybe a little bit more prevalent in areas like that. The other people that you may or may not consider that are susceptible to tuberculosis are people who are on anti-inflammatories, people who have autoimmune suppression, so people on chemotherapy. Yes, Morgan.
I have a question about jail. When people like go to them, they even check like it's for jail.
I couldn't tell you.
I mean, it would just feel like kind of a dull moment. Because I mean, yeah.
When you think about it, you have a captive audience. You should be getting them up to date on the immunizations, right?
Well, I mean, because well, no, I mean, I was checking. Yeah.
One of our not recent, but a couple of years ago, one of our graduates actually got a job at one of the prisons in South Dakota. I would be so interested to know her experience.
Really one of our other books that like nursing home clients are
Correct. Yeah.
They do that same thing as the prison population. Do they give us here?
I do not know, but it would make sense. Like I said, you've got right? Okay, sorry, didn't mean to get off topic. It's a great discussion topic. I appreciate
I
that.
have a family friend that works at
Please do. I'd love to know. It would only make sense. I mean, let's get them up to date on EBTs. Let's get them up to date on influenza. But that's just me. I might be a little bit control freak. Okay, we're going to go to page 377 so we don't get too far off track here. 377. The other medications in this chapter that I'm going to focus on is antifungals. And the two prototypes, amphotericin B and ketoconazole for our prototypes for this little part of this chapter. You want to highlight those two prototypes. On page 378, under complications for our antifungals, complications, infusion reactions. Remember, these medications are very strong. So, complications can cause infusion reactions, fever, chills, rigors, headache, 1 to 3 hours after initiation. And for a nursing consideration, once we're starting these medications, it is very common to do a test dose of 1 milligram of amphotericin B infused slowly, and then watch for any sort of client reaction, meaning chills, rigors, headache. Rigors is like stiff muscle spasms. It's also very common that we pre-treat with diphenhydramine, Benadryl, and acetaminophen. We used to have this dear gentleman who came to the emergency department back when I started in wherever, because HIPAA says we can't talk about stuff like that. But this dear gentleman had a lung fungal infection, and I'm not kidding, he came for like it was over 9 months. And he would come daily for IV amphotericin, the antifungal. And he just I felt really bad because you could see over the time that he just kind of wasted away. The amphotericin probably kept the fungal infection control, but he never got rid of it. It is that hard to get rid of. So, but we would always he would have the chills with the amphotericin, so we would pre-warm his bed with a nice warm bath blanket, and then as soon as he hit the bed, we'd put a nice warm blanket on top of him. We'd start his amphotericin, and it sounds bad, but we'd pop him a couple of acetaminophen. We'd give him a little diphenhydramine so that he wouldn't have so many so much discomfort from it. And he'd be there for 2 hours, and then we disconnect him. Out the door he would go. But it really, some of these same infusion reactions we saw with him. But again, it's the tough thing to get rid of. The topical antifungals that you will work with in a clinical setting are usually for treatment of skin disorders or a candidiasis. So some of those topical things would be topicals aren't systemically absorbed, so you won't see some of these severe kind of reactions, complications from them. Just remember, all of this stuff in your ATI book and these ATI chapters is important, but I'm just pointing out some of the highlights of that chapter. And remember, I'm not too proud that I won't take some of the application exercises from the end of the chapter. But when you read those application exercises, don't just know them for, I know that question number 1, the answer is B. I want you to know that, especially if there's a SATA that says, was there a SATA on here? Yeah. Oh no, I don't want to take that one. We'll take another application exercise, and I'll give you a question. Because sometimes I turn it around. I might say, if you're going to teach a patient all these things that they should remember, remember the question on the test might be, when you're teaching your patient, what thing we maybe not teach. But just don't know them I don't want you to just memorize them. I want you to understand it a little bit. So, next. I think we will go, I'm going to extend you to chapter 17, which is on page 125 of your ATI book. Airflow disorders. So, besides common and influenza and allergies and things like that that cause some of our respiratory discomforts. Airflow disorders that we see a lot in healthcare setting, asthma. And asthma is chronic, and it's actually an inflammatory disorder, meaning inflammation. There's swelling, more mucus production, constriction of the airway. So asthma, quite often, people have asthma, you'll hear wheezing. Airflow disorder. The other type of disease process that you see a lot when you're talking about airflow disorders is chronic obstructive pulmonary disease. COPD. And depending on a person's lifestyle and habit, COPD can be preventable. Name one lifestyle choice that for sure you might see somebody with COPD. Tobacco use, right? Smoking. Knowing our agricultural background in this area. Remember, farmers, even though they don't use tobacco, still have that potential for COPD just because they're exposed to lots of dust. We try to minimize it, but chemicals. I think I'm going to get COPD because every morning, every night when I do chores, there's speed dust, and I'm going, I think I'm getting COPD. I try to hold my breath, but it doesn't work. So, okay. Anyway, so 2 things that you're going to see when you go in the hospital setting, and I guarantee it, besides the usual flus, colds, RSVs, snotty noses, things like that, asthma and COPD you see a lot. So we're going to talk about airflow disorders. We're going to talk about albuterol. That's our prototype for airflow disorders. That's one of them. And under expected pharmacologic action of albuterol, it's pretty fancy here. It says beta-2 receptors in the bronchial smooth muscle resulting in bronchodilation. So think that albuterol is going to make breathing easier. So ease the breathing. Albuterol is going to open the airways. And it's going to relax those bronchial smooth muscles. So it's going to ease respiration, make it easier to breathe, open the airways, and relax bronchial smooth muscles. It's a great medication. It works good for opening airways, but look on the other side of this page where under complications, people take albuterol either as an inhaler or a nebulizer. They usually get tachycardia, meaning faster heart rate. Their heart will start going. It also causes tremors. When you're given an albuterol inhaler, especially the first time, on albuterol neb, look for restlessness, nervousness, tremors, tachycardia. I'm going to turn to page 126. Under nursing administration, kind of the second bullet down under nursing administration, when a client has prescriptions for inhaled beta-2 agonist and an inhaled glucocorticoid, always, so you have, how do I say this? So you have albuterol, which open the airways, And then you have also an inhaled glucocorticoid, which helps kind of stabilize, suppress, inhibit inflammation. Always take the albuterol first so that it opens the airways. And then the glucocorticoid, which is going to kind of keep things set down, then the glucocorticoid can get further into the lung and be more effective. Always go with the albuterol first, which is the beta-2 adrenergic agonist.
So for the glucocorticoid, second, that would be the second to inhale, or
Right.
is that
So it can be inhaled.
so what will be?
Methylmethasone, thank you. Which will be one of our.
And the methylmethasone you take like all the, I mean, it's a long, quite a day. Yeah,
That's the other good point here, yes.
Yeah.
So albuterol can often be used as what they call rescue, like when people start feeling tight in the chest, more wheezing, they might take a puff of albuterol, which opens the airways. But the beclomethasone, the glucocorticoid, is more of a take it every day to help inhibit that inflammation. That makes sense. Always take your albuterol first because it's going to open the airway. Take your maintenance therapy second. And there's usually wait in between. It's not like you puff your albuterol and puff your glucocorticoid. Usually wait at least five in between. Okay. So you highlighted the second bullet under nursing administration, hooray. The reason you would have maybe an inhaled glucocorticoid, and that inhaled glucocorticoid is inhaled, it is well absorbed, but it's not like taking a pill of a glucocorticoid, which would affect your own blood sugars. It's not that it's not going to affect it, but the reason they have it inhaled is it limits the systemic effect. So, okay. Underneath the nursing administration, there's a little image of a metered dose inhaler. MDIs deliver medication to the site and avoid systemic effects. I wrote myself a note about that. So you'll see MDIs, which are metered dose inhalers. You'll also see DPIs, dry powdered inhalers. Sometimes those dry powdered inhalers are actually a little bit better for like people who have don't have a lot of coordination, because this metered dose you actually have to push and then inhale, but dry powdered, you stick the capsule in there, or else you click it to the right measure, and you don't have to push and puff, you just put it up to your mouth and suck it in. It's important when they are using those dry powdered inhalers, try to get your patients not to exhale into them, because the moisture kind of dumps it up. So, all right. Also on page 126, under the selected prototype, there's theophylline. Theophylline used to be huge in medicine because it causes relaxation of bronchial muscles, resulting in bronchodilation. We don't use it as much anymore. You may see theophylline used more as an emergency type medication. If the patient's albuterol is not working for them and they are having a real bad time with their COPD, they might come in for some theophylline. The concern with theophylline is under complications. Complications for theophylline, it has a very narrow therapeutic range. And so patients on, it's under nursing considerations, Monitor theophylline serum levels to keep within therapeutic range. I'm not gonna quiz you on the therapeutic range. Just know that theophylline you have to check a therapeutic range on theophylline. Because too much, you get a little toxic. And too little, you're not helping your patient lung problem. On the next page 127, interesting interactions for theophylline. Interactions is caffeine. And caffeine can increase the central nervous system and cardiac adverse effects of theophylline. Caffeine can also increase the theophylline level. I always thought it was very interesting. Back in Minnesota, we had this very bad asthmatic lady. She was like 40 years old, looked older than her stated age. She looked really tough. And she had bad asthma. And she, when her asthma was flaring up, it was usually during the spring and during the fall. It's something about the dust in the air that just made her asthma worse. But she would take her medications at home like she was supposed to, and then she would drink some really strong hot coffee because that coffee was actually caused a little bit of a bronchodilation effect. But if all of those things, even the strong coffee wasn't working for her, she would come in and we would plug her into theophylline. And her heart would be just tacking away there. She was a tough lady. Asthma is not a condition to live with. So that's my spiel about theophylline. Inhaled anticholinergics, our select prototype, we're still on page 127. Inhaled anticholinergics is ibuprofen. Again, it's supposed to relieve, its purpose is to relieve bronchospasms associated with COPD. Because it is an inhaled anticholinergic, it is very normal for patients to have dry mouth. It like dries up their mucous membrane. They'll be hoarse. They'll talk like very, very, I want to say, like you smoked 2 packs a day. So those are some of the expected effects of inhaled anticholinergic. Okay, next page 128, glucocorticoids. So here our select prototype medications are beclomethasone. And we know that's great because it doesn't provide systemic effects. But if the patient has a flare-up when they are really, really sick, they may be put on prednisone, or they may even get IV hydrocortisone. For the most part, if they are taking their medications and using beclomethasone, hopefully they can avoid a flare-up. The purpose of the glucocorticoids, the expected pharmacologic action, prevent inflammation, suppress airway mucus production, and promote responsiveness of beta-2 receptors in the bronchial tree. The purpose is also to reduce airway mucosa edema. It's just trying to avoid that hyper-responsive reaction that the body is exposed to. And some people are very different, like their asthma can flare up from seasonal dust. Some people, their asthma can flare up from perfumes. Some people, their asthma can flare up just being in a hot room. So, or being too cold. So hopefully your asthmatic has kind of kept a little bit of a health history, a diary, what triggers their asthma, what triggers a flare-up. Okay, so complications, we're going to go down the page here. Complications, beclomethasone. Difficulty speaking, hoarseness, candidiasis, which is oral yeast infection. candidiasis. Candidiasis can be oral, it can be vaginal, it can be, candidiasis can be in skin folds. You might see candidiasis on people who have morbidly obese people and they have large penis, large tummy flaps, and underneath there it's nice and warm. The yeasties like to grow there. So, okay, beclomethasone, difficulty speaking, Horson's candidiasis. Advise your client to rinse their mouth or gargle with water after use. That helps minimize potential for candidiasis. Also, advise your client to monitor for redness, sores, or white patches and report to the provider if they occur. Treat candidiasis with nystatin oral suspension. So remember, for complications for beclomethasone, hoarseness, dry mouth, also like change in taste, it can alter their taste. They're normal things that can occur. On the other side of the page on 128, prednisone. Prednisone, when used for 10 or more days, can result in, I'm going to jump all the way down, almost to the bottom of the page where it says infection. Nursing considerations. Advise your clients to notify the provider if early manifestations of infection occur. Sore throat, weakness, malaise. We're all feeling malaise. This is the end of this, almost the end of your theory. You're all tired. We don't ache all over, I hope, but malaise is you're tired, you're worn out, you ache all over, you don't want to do anything. Okay, so next page, 129. Under interactions, we're going to think about, oh, I'm sorry, we're under nursing administration, sorry. Here we go. Nursing administration. Instruct clients to use glucocorticoid inhalers on a regular, fixed schedule. Like Kim said, maintenance. For long-term therapy of asthma. Glucocorticoids are not to be used to treat an acute episode. Always go albuterol first, open the airways, then do your glucocorticoid for a flare. Okay? That is all. Remember your application exercises at the end. Yes. That's it.
All right. We were talking about the TV thing first. Okay. Really great.
Cool. You think it would be a state program that it would be health promotion, right? I didn't highlight anything. Everything in this chapter is important, but I didn't highlight anything. Okay, is now a good time? Let's take a little video thing for, let's see if I can find the, well, of course, TigerNet kicked me out. Let's try here.
Probably gonna have to turn the volume way up.
Okay, I will try. Hey, yeah.
Always getting on the sidelines after an Africa. Is that something better? Yes. His doctor prescribed a new medicine for him. Sometimes beclomethasone, also called QR. It's a long-acting corticosteroid that he takes every day. So it works better than well, no, it works differently than it reduces the inflammation on a daily basis and opens up his airways so he doesn't need his rescue inhaler as long. He still carries his rescue inhaler for flare-ups, but they don't have him as often nowadays on beclomethasone. It has been great. He is really enjoying playing soccer again this year. Now if he lands in the ER, it's more likely because of a broken bone than an athlete.
Yay.
Beclomethasone is used to prevent difficulty breathing, chest tightness, wheezing, and coughing caused by asthma in adults and children 5 years of age and older. It belongs to a class of medications called corticosteroids. It works by decreasing swelling and irritation in the airways to allow for easier breathing. Beclomethasone comes as an aerosol to inhale by mouth using an inhaler. It usually is inhaled twice a day. Follow the directions on your prescription label carefully and ask your doctor or pharmacist to explain any part you do not understand. Use beclomethasone exactly as directed. Do not use more or less of it or use it more often than prescribed by your doctor. Talk to your doctor about how you should use your other oral and inhaled medications for asthma during your treatment with beclomethasone inhalation. Beclomethasone controls symptoms of asthma but does not cure it. Improvement in your asthma may occur as soon as 24 hours after using the medication, but full effects may not be seen for 1 to 4 weeks after using it regularly. Continue to use beclomethasone even if you feel well. Do not stop using beclomethasone without talking to your doctor. Call your doctor if your symptoms or your child's symptoms do not improve during the first 4 weeks or if they get worse. Beclomethasone helps to prevent asthma attacks, but will not stop an asthma attack that has already started. Your doctor will prescribe a short-acting inhaler to use during asthma attacks. Tell your doctor if your asthma worsens during your treatment. Do not use your beclomethasone inhaler when you are near a flame or source of heat. The inhaler may explode if it is exposed to very high temperatures.
Before you use beclomethasone inhaler the first time, read the written instructions that come with the inhaler. Tell your doctor and pharmacist if you are allergic to beclomethasone, any other medications, or any of the ingredients in the beclomethasone inhalation. Tell your doctor and pharmacist what prescription and non-prescription medications, vitamins, nutritional supplements, and herbal products that you are taking or have recently taken in case of interaction. Tell your doctor if you have or have ever had tuberculosis, cataracts, glaucoma. Also tell your doctor if you have any type of untreated infection anywhere in your body. Tell your doctor if you are pregnant, plan to become pregnant, or are breastfeeding. If you become pregnant while using beclomethasone, call your doctor. Tell your doctor if you have never had chickenpox or measles and you have not been vaccinated against infections. Stay away from people who are sick. Unless your doctor tells you otherwise, continue your normal diet.
Beclomethasone inhalation may cause side effects. Tell your doctor if you have any of these symptoms are severe or do not go away. Headache, sore throat, runny or stuffy nose, back pain, nausea, cough, difficult or painful speech. Some of the following side effects can be serious. Call your doctor immediately or get emergency medical treatment for rash, hives, itching, swelling of the face, throat, tongue, lips, eyes, hands, feet, ankles, or lower legs, hoarseness, difficulty breathing or swallowing, or changes in vision. Beclomethasone inhalation may cause children to grow more slowly.
I love that little kiddo.
While your child is using beclomethasone. In rare cases, people who use beclomethasone for a long time develop glaucoma or cataracts. Talk to your doctor about the risk of using beclomethasone and your eyes impairment during your treatment.
Why do you ride a car with you are?
Pretty handy. Nice. Nice that you have that.
To be on that. I don't have the box.
Perfect.
I don't want to shut this whole thing down. Oh, we're good. Still recording too. All right.
Okay, so, we go to chapter 18 next, upper respiratory disorders. So medications that people use for upper respiratory disorders usually associated with things like colds, coughs, influenza. Some of the antihistamines, especially for associated with use for treatment of allergic rhinitis. Antihistamines, remember, are used for more than just things like anti-nausea, preventing flare-ups of seasonal allergies. Motion sickness, they use antihistamines for allergic reactions. Diphenhydramine is one of our favorites, especially somebody's having an allergic reaction, an anaphylactic reaction. They also use antihistamines for insomnia. So the concern is when you're using antihistamine, maybe to treat allergic reaction, allergic rhinitis, treatment of motion sickness, antihistamines for treatment of seasonal allergies. Sleepiness is usually one of the side effects that we have to teach our patients about. So if they're taking some antihistamine, tell them maybe you shouldn't drive to the city because it can cause some sleeping. 10 minutes home or 20 minutes home, your patient's probably going to be okay. But if they take an antihistamine and then plan to drive to the cities, they might fall asleep at the wheel. So we got to tell them to be careful about that. Elderly people can especially be sensitive to that because they metabolize medications in a different way. So if they're taking antihistamines, it can make them sleepy. It can affect their coordination, so they're more at risk for falls or injury. Other medications in this section usually frequently combined with for increased effectiveness. So meaning they'll sometimes put cough medicine with one of the opioids. Opioids are great for suppressing that cough, but they also might put it with something that helps loosen the mucus a little bit. So antitussive opioids, the prototype is codeine. We just know that some of those opioids can automatically make not everyone, but opioids can make people sleepy. So again, be aware, tell your patient, good patient teaching can make you sleepy. Interestingly enough, we don't dispense as much Robitussin AC, Robitussin with codeine like we used to, because of the concern about opioid addiction. So you usually try other things. Okay, antitussives, non-opioids. You can go get over-the-counter dextromethorphan pretty much at any Walmart, grocery store, pharmacy these days. So dextromethorphan is our antitussive non-opioid. Please read the label. Usually, dextromethorphan is not for children less than 6 years of age. The good thing about dextromethorphan, it follows its purpose, expected pharmacologic action. Dextromethorphan suppresses the cough. I'd like to make an addendum to that. It will suppress a non-productive cough, meaning the little dry cough that you sometimes get when you got a cold, and you don't have bronchitis or you don't have sinusitis, but you got a dry, happy cough. But dextromethorphan just suppresses the cough. It's not good for dry coughs. Interactions for dextromethorphan on page 134. It can cause, here it says it can cause high fever when used within 2 weeks of MAOI antidepressant. Oh, I just lost my list of MAOI antidepressant. Somebody who's got a Google page open, please tell me an MAOI antidepressant. Anybody? Like a shout out, please. Arnie. Phenylazine. Oh, no, that one. Phenylazine. Why don't you write down a phenylazine beside the. Could you spell that, please? PHEN. Oh, I'm sorry. Very good. Page what? 58. Page 58 in your ATI. Very good. Thanks. So just know interaction. be the high fever thing. It's more, you get some really funky interactions. The concern about the dextromethorphan is like, it can cause like, it hasn't been that long. Students, young people who are going to the grocery store and getting a bottle of dextromethorphan and drinking the whole thing and it gets so high. So then you get some weird overdose type reactions. So dextromethorphan's great. Just know it can cause some weird reactions, and it's not for children under 6. And it's only for non-productive coughs. Okay, next one is, our prototype on 134 is expectorant is guafenicin. Guafenicin's purpose promotes increased cough production by increasing and thinning mucus secretion. And because it can increase and thin mucus secretions and the patient can expectorate them, cough it out, it actually helps with the patient's airway clearance. It promotes airway clearance, okay? Because they get rid of that mucus. They get rid of the blockage. So remember how guafenicin works. Increases and thin secretion. So patient can get rid of them. The other thing I'm going to tell you, so you're going to give your patient this guafenicin, which is an expectorant. Over under nursing administration on the other side of the page, I'll advise your client to have adequate or increased fluid intake when taking guafenicin. That just helps promote liquefaction and expectoration. Love the short words, right? All to help clear that airway, promote airway clearance. Okay, next under mucolytics is acetylcysteine. Acetylcysteine. Mucolytics, acetylcysteine. I know it as mucomist, but the generic name is acetylcysteine. Purpose: mucolytics thin and enhance the flow of secretions in the respiratory passages. This used to be one of the standard treatments for kids with cystic fibrosis. They would come in and get these acetylcysteine nebulizer treatments to help open their lung passages, promote getting rid of all that sticky mucus that was causing the problem with cystic fibrosis. Interestingly enough, you know I love antidotes. So acetylcysteine is the antidote for acetaminophen poisoning. Yes, I like that one. I love it. I love my antidotes. I promise I won't get calcium gluconate, potassium gluconate picked up anymore. Acetylcysteine, I'm going to take you to the next page, 135. Under nursing administration. Acetylcysteine, advise clients that acetylcysteine has an odor that smells like rotten eggs. So imagine how pleasant that is for somebody who's got cystic fibrosis and they have to have this as like a nebulizer and they're breathing this in. But kids with cystic fibrosis know that some of these medications help them feel so much better that they put up with it. It's just crazy. The tough part is if you've got somebody who's had a suicide attempt by overdosing on acetaminophen and they already feel bad, they already don't want to sometimes get better. It's tough to get your acetaminophen overdosers to actually take this stuff orally. So you try whatever works. It does say you can give it IV, but oral, we've always given it orally for some reason. You put this acetylcysteine in a styrofoam cup and you pour in like soda. I think we used to use root beer. And then you put the cover on and you put the straw in the middle and you tell them to suck way at the back of the mouth so that they don't have to smell it as much. But rotten eggs, it really does stink. And it's usually, if it's for acetaminophen overdose, it's more than one dose. You gotta, if their acetaminophen level is high enough, they have to take it like quite regularly, every 4 hours. So it's a tough thing to get your patients to take something. Okay, also on page 135, we're going to go for decongestants. Phenylephrine, also known as Afrin. Afrin, also pseudoephedrine, also known as Sudafed. Those medications, whether whatever you're taking it for, is supposed to, under purpose, cause reduction in inflammation of the nasal membrane. Goal is to relieve nasal stuffiness, decrease stuffiness. So patients come in and they say, I've been using Afrin for like the last 10 days and I'm not getting any better. My symptoms are just getting worse. The reason is, under complications, especially this topical phenylephrine, it has rebound congestion. If patients are using it longer than 3 to 5 days, it actually has almost like the reverse effect. They get stuffier instead of getting some of that nasal congestion relief. So that rebound effect will always get them if they use it for too long of a period. Page 136, contraindications and precautions. If you have patients who are taking, especially oral Sudafed, pseudoephedrine, contraindications and precautions, these medications are contraindicating in clients who have closed angle glaucoma. Hopefully your patient has been treated for their closed angle glaucoma within 1 to 2 days, otherwise they're going to suffer blindness anyway, right? That's what we learned from last unit medications. The other thing, if patients are taking Sudafed, it has to be used cautiously in clients who have coronary artery disease, hypertension, cerebrovascular disease, dysrhythmias. Add one more thing to that list. If you have older male clients who have prostate enlargement, prostate hypertrophy, pseudoephedrine can actually cause them to not be able to pee. They can't urinate. So use cautiously all of those people that are listed there, but add prostate enlargement, prostate hypertrophy. It's important. Next, down on the list here on page 136, nursing evaluation of medication effectiveness. Depending on therapeutic intent, effectiveness is evidenced by improvement of manifestations, meaning hopefully it's going to relieve their congestion and make it easier for that patient to breathe. Okay, also on page 136, antihistamines is our next category, like Jeopardy categories, antihistamine. Diphenhydramine, or prototypes, diphenhydramine, also known as Benadryl. Promethazine, also known as Phenergan. Dimenhydrinate, brand. Another antihistamine, loratadine. Zyrtec? Nope, sorry, Claritin. Claritin, sorry. Loratadine, also known as Claritin. Those are our prototypes for this one. Jumping down on the page, under complications, patient may experience sedation, sleepiness. Highlight that bullet, avoid driving or other activities that require alertness. Know that antihistamines, especially when taken with alcohol, can compound that sleepiness effect. So you have to tell your patient to minimize or avoid the use of alcohol when they're taking their antihistamines because they don't know how sleepy it's going to make them, right? Other CNS depressant medications, barbiturates, benzodiazepines, and opioids can also potentiate that sleepiness problem. Antihistamines, especially like diphenhydramine, Benadryl, is also well known for its anticholinergic effect. It makes people so very dry. Okay, jump to page 137, contraindications and precaution. Antihistamines are contraindicated during the 3rd trimester of pregnancy for mothers who are breastfeeding and for newborns, because we know newborns are especially sensitive to adverse effects like the sleepiness, the CNS symptoms that go along with that. Okay. Did I highlight anything? Please do review nasal glucocorticoids. The prototypes here are mometasone and fluticasone. I don't have anything especially highlighted under there. Please at least be able to identify nasal glucocorticoids if you see them, because you may see them, your patients may be using those in the hospital setting. We're pretty darn close to that. I'm kind of excited. Again, please don't forget to review application exercises on page 138. Ta-da. Okay, that's chapter 18 done. Let's do chapter 19, medications affecting urinary output. So we're going to be talking about diuretics. Diuretics make your patient's kidneys work to excrete fluid. Diuretics should make urine. Let's knock on wood. Diuretics should make urine. Indications for medications affecting urinary output. Indications affect urinary output. So you will use diuretics to treat high blood pressure. Help patients excrete excess fluid when they have edema related to heart failure, kidney disease, liver disease. Sometimes they also use it for prevention of kidney failure, but I guess I don't know that as much. Sometimes I suppose patients are on it, but I maybe don't know the reason why. Okay, so prior to using any sort of diuretics on your patient, get your baseline. Assess your vital signs. Get that pulse. Know blood pressure prior to your diuretic start. That's not in your notes, but that's from me. And that's the right thing to do as an accountable nurse. Always assess vital signs. Temperature, not so much. Your respirations may be affected if you're trying to get rid of a lot of fluid, but pulse and blood pressure prior to diuretic start. So when you're giving these diuretics, how are you going to know that they're being effective? The kidneys are kicking out some fluid, right? You're seeing some pee, urine output. And for long-range use of diuretics, how do you know that your patient's diuretics are actually working to their benefit? Did anybody say daily weight? I hope so, because daily weight is going to be your long-term determination of effectiveness of diuretics. Because if your patient's taking their diuretic on a daily basis, every day, yep, I'm taking my 10 milligrams of furosemide. Yep, I took my 10 milligrams of furosemide. But all of a sudden, your patient's put on 2 pounds. Your patient's gained 4 pounds. That's an indication that maybe that diuretic isn't kicking out the fluid like it should. So maybe they have to come back in and be reevaluated. Maybe they need a different medication. But daily weight is going to be the greatest long-term reflection of fluid balance. Somehow I wrote myself a note down at the bottom of this page. If you are caring for someone and they do have renal failure, What medication do you not give them for pain relief? Who said ibuprofen? Don't give your patients with kidney failure any sort of NSAIDs. NSAIDs are hard on the kidneys. This should come back to you from like Unit 1, right? We talked about pain relief. Don't give NSAIDs to your patients who have kidney failure. Okay, so we're going to move on here. Page 143. High loop, high ceiling loop diuretics, furosemide, also known as Lasix. I still see a lot of this given in the hospital setting. Furosemide. Furosemide. On page 143, furosemide can cause complication. And I highlighted hypotension. So you take fluid out of the body, there's not as much vascular resistance, there's not as much fluid in there pushing against the vessels, so it can cause hypotension, lower blood pressure. So sometimes this is used for treatment of high blood pressure. So hypotension is one of the complications. So we need to monitor the blood pressure. Oh, monitor the blood pressure and heart rate. Did I say that enough yet? Okay. Instruct your clients about manifestations of postural hypotension, lightheadedness, dizziness. And everybody's experienced this for sure. It's like you're sound asleep, the alarm goes off, and you realize, I have 5 minutes to get to class. You jump up out of bed, and you go like, whoo, you're a little dizzy. That's what happens. That's called postural hypotension. Your body can't, your heart can't equalize. If you stand up, fluid rushes to your feet, and you don't have enough circulation in your brain. That makes sense? So postural hypotension is one of the concerns. Advise your clients to avoid sudden changes of position and arise slowly from lying down or sitting. Another complication of furosemide, ototoxicity, causes hearing problems. Under nursing considerations under ototoxicity, advise your clients to notify the provider of tinnitus, ringing in the ears, which can indicate ototoxicity. Ringing in the ears is not always your phone. Sometimes it's furosemide toxicity. Okay? Hypokalemia. So you take this tiny little kiss of furosemide, and it turns your kidneys on high speed, and it's kicking out all kinds of fluids. It can flush out a lot of potassium. The furosemide is quite well known for causing hypokalemia. If you have a patient on furosemide, check their MAR, check their medication administration record. They better be having a little potassium supplement in their daily med. Not daily breaths, daily med. Okay? So, hypokalemia. And this is the one lab value I'm going to ask you to know. I think I warned you about it last unit. Know your potassium level. 3.5 to 5. That is your normal potassium level. 3.5 to 5. That's not a lot of wiggle room. Remember, our bodies are like Goldilocks. We don't want too much. That's called hyper. We don't want too little. That's hypo. We want it just right. We want a normal potassium level. 3.5 to 5. Remember that. Fair warning. So I'm also going to say, so if we are giving our patient maybe a little bit of potassium supplement, how else can we help them get more potassium in their diet? Bananas. Here, we have it listed so well here. Teach your client to consume high potassium foods. Bananas, potatoes. They say baked potatoes with the skin on. Potatoes like sweet potatoes, high potassium. Dried fruits, dried apricot, dried dates, dried banana chips, dried fruits. Remember some of those dried fruits. Nuts, spinach, spinach and citrus fruit. Not grapefruit. Orange juice. Orange juice. A good potassium source. Hint, hint, nudge, nudge, wink, wink. Know which foods to recommend to your client. It won't vary much from this, but you need to be able to pick out some high potassium foods. Okay, know some of the signs and symptoms that you have to teach your patient about signs and symptoms of hypokalemia. Nausea, vomiting is under your hypokalemia. Nausea, vomiting, fatigue, leg cramps, generalized weakness. Know those signs and symptoms of hypokalemia. Okay, turning to page 144. Interactions. Furosemide and digtoxicity. Digoxin toxicity can occur in the presence of hypokalemia. That's why it's always important. When your patient's on furosemide, make sure they've got a potassium supplement, make sure they're taking foods high in potassium. Because if they go hypokalemic and they are also on dig, it can cause toxicity. And if your patient's dig toxic, their heart is going to go wacky. Okay, nursing considerations, monitor the cardiac status, potassium and digoxin levels, potassium-sparing diuretics sometimes are used in conjunction with loop diuretics to reduce the risk of hypokalemia. Just remember, the more medications you add, the more side effect complications that are associated with that. So that I thought that was kind of an interesting thing. But sometimes you do see patients on like furosemide, which takes out potassium. You might also see them on spironolactone, which holds in potassium. Crazy. Administer potassium supplements as prescribed by the provider. A little further down on page 144 under nursing administration, obtain a baseline data, including orthostatic blood pressures, weights, electrolytes, and location and extent of edema. I had a dear little lady who wanted to know what edema was. And I was like, edema. She was trying to say edema. Weigh clients at the same time each day with the same amount of clothing and bed linen if you're using a bed scale. Usually first thing in the morning. But don't do it at the end of the day. Don't do it when you're dressed in your insulated coveralls versus in your pajamas, right? There's a big difference there. Try to maintain same amount of clothing, same time of day, same scale. Because patients will come to the hospital and step on our scale and go, oh, I don't weigh that much. Well, maybe you do, but at home your scale is probably 5 pounds less, right? Okay, so next, nursing administration, monitor blood pressure and I&O, and take an output. Here's the other thing about, especially furosemide, Lasix. There's a reason why it's called Lasix. It's usually because the Lasix lasts 6 hours. So avoid administering the medication late in the day to prevent nocturia. Don't want your patients getting up in the middle of the night, go pee because they took their Lasix at 8 o'clock at night. They got full of catheter, no big deal, but especially for elderly people who might be on these diuretics, don't want them stumbling to the bathroom in the middle of the night, increase their chances of falling. Usually, if your patient's on a once daily diuretic, usually first thing in the morning, but usually no later than 4 o'clock in the afternoon. Here it says 8 to 2, but again, we usually try not to give Lasix after 4 o'clock. Okay, nursing evaluation of medication effectiveness, also on page 144. Depending on the therapeutic intent, effectiveness is evidenced by a decrease in pulmonary or peripheral edema. And the way you can tell that your pulmonary edema is getting better is your patients will breathe easier, They won't breathe as fast, and they won't have as many crackles. Then you know your furosemide's working. Also, the weight loss, the decrease in blood pressure. But if you're talking about edema, pulmonary or peripheral, look for decrease in edema, decreased respiratory rate, easier breathing, less crackles. Do they give this? Pneumonia, not it's not a fluid consideration. It's more of a pathogen causing obstruction that type. Not to say that if they have pneumonia, they might also have PHF, and that might cause flare of what it's complicated that. Page 144, also therapeutic uses. Next, we're going to go to thiazide diuretics, hydrochlorothiazide. Hydrochlorothiazide under therapeutic uses. Thiazide diuretics are often the medication of first choice for essential hypertension. When they are using diuretics to treat hypertension, they usually try to go with the simplest once daily medication, because that simple once daily medication actually promotes compliance, meaning the patient will actually, HCTZ.
Well, I've seen it. Different blood pressure, whatever it is, and HCl. But
that's for hydrochloride, isn't it?
Yeah.
I don't know. I'd have to look at that. Hydrochlorothiazide is often abbreviated HCTZ. Yep. So that's therapeutic uses. I thought it was kind of interesting under hydrochlorothiazide. The last bulleted item under therapeutic uses is promote reabsorption of calcium and can reduce the risk for postmenopausal osteoporosis. I thought that was kind of interesting. I don't think I've ever seen it given for that reason, but obviously it's there. So, okay, we're going to go to page 145, complication. So we give this lovely diuretic. Complications, give a diuretic, bring out all the fluid in their body, can cause dehydration. Dehydration and hyponatremia, low sodium. So nursing considerations, we have to actually watch our patients so if we could monitor them for some of these manifestations of dehydration. Dry mouth, increased thirst, minimal urine output, and weight loss. We also have to monitor their electrolytes and weight, and report urine output less than 30 mils an hour. If your patient isn't putting out urine 30 mils an hour, stop, notify your provider. Also on page 145, under complications, hypokalemia, meaning low potassium. I figured I could get it until we break it. We will. It'll work. Thank you. Hypokalemia, especially noted, bullet number 4 under hypokalemia, teach your clients to recognize manifestations of hypokalemia. I think this is the second time we did this. Nausea, vomiting, general weakness, fatigue, leg cramps. It must be important. Contraindications and precautions. I'm always a big sucker for medications in pregnancy. Avoid administering thiazide diuretics during pregnancy because the medication decreases the maternal blood volume, and then the baby doesn't get the full meal deal because the placenta is not getting perfused. The baby's not getting nutrients, it's not getting fluid, he can't grow. Okay, other side of the page, on page 145, nursing administration. Bulleted item 1, 2, 3, 4. After monitor potassium levels, of course that's important. Instruct your clients to take the medication first thing in the morning. If twice a day dosing is prescribed, be sure that the second dose is taken by 2 o'clock, 1400 or in nocturia. And then also encourage clients to consume foods high in potassium. You're going to know all your potassium foods. And maintain adequate fluid intake unless it's contraindicated. There are some kidney failure clients who are on dialysis that have a really specific fluid limit that they can have. But maintain adequate fluids if you're taking this medication, because otherwise you're more at risk for dehydration. The fluid that is best for our clients, water, plain old water. Okay, that might be an answer to some questions. Water. Water is best. Nursing evaluation of medication effectiveness, depending on therapeutic intent. Effectiveness, evidenced by decreased blood pressure, decreased edema, increased urine output. They also use it for diabetes insipidus, but that's not going to be on the test, but it is kind of interesting. And then also, I'm not familiar with the bone integrity and postmenopausal limits. I just have not seen that, but it's there. They must be using it for it. Okay, we're going to go to page 146, potassium-sparing diuretics. Spironolactone. Because spironolactone allows the body to retain potassium. The complication for potassium-sparing diuretics, spironolactone, is hyperkalemia. So if you've got a patient on spironolactone, think twice before you do bulleted item number 4 under hyperkalemia. Please consider or do not administer potassium supplements or other potassium-sparing diuretics in conjunction with spironolactone. Please do not give spironolactone if you get a lab result back and your client's potassium is 5. As we know, 3.5 to 5 is a normal potassium level. And your patient's got spironolactone and you see that their potassium level is 5 and you're reaching for spironolactone, stop. Do not give it. Call your provider. You don't want them to retain any more potassium, right? Okay, over on the other side of the page, nursing administration. Besides obtaining a baseline data on pulse, blood pressure, and weighing the clients at the same time every day, go down to bulleted item number, 1, 2, 3, 4, 5, 6. Teach clients to avoid salt substitutes that contain potassium. And they may actually have to avoid things like bananas. Don't have a banana smoothie every month if you're on spironolactone. Reduce the intake of potassium-rich foods such as oranges, bananas, dates. Give up that 10 dates every morning. Okay, it's important. Not kidding. Page 147. Oh, osmotic diuretics, mannitol. Osmotic diuretics suck fluid back into the vascular system. So expected pharmacologic action. Osmotic diuretics reduce intracranial pressure and intraocular pressure by raising serum osmolarity and drawing fluid back into the vascular, extravascular space. So all this excess fluid that may be in the, here it says in the brain, but think also about peripheral edema. You give some mannitol, it draws the fluid into the vascular system. So now you've got extra fluid circulating in your vascular system. Better make sure your kidneys are able to get rid of it. Because if you've got extra fluid in your vascular system, where are you going to hear crackle? Oh, you're going to hear lots of crackles in the lung. Patients are going to become more short of breath. They're going to have edema in their lungs. So under contraindications and precautions, this medication is contraindicated in clients who have an active intracranial bleed, but anuria, meaning no urine. Their kidneys aren't working. Their kidneys aren't working to get rid of it. You're going to be dealing with it in other ways. It's going to be sitting in their lungs. Renal failure. That's another contraindication precaution. That's all in this list of contraindications precautions. Nursing evaluation of medication effectiveness over on the other side of the page, on page 147. Normal kidney function should be demonstrated by a urine output of at least 30 mils per hour. Again, our application exercises on page 148. Let us begin chapter 20. Let's begin chapter 20. Medications affecting blood pressure. This is on page 151 of your ATI book. So these always make students nervous, and I apologize for that, but it is what it is. We got to have some good medication, some good antihypertensive medication. And high blood pressure, I'm not kidding, can kill people without them even ever knowing that they've had high blood pressure in subtle little ways. High blood pressure affects all systems. It doesn't necessarily make you have a heart attack and drop dead, or have a stroke and drop dead. High blood pressure, untreated, can cause renal failure. And that's always so very serious, because patients don't even know that they've got high blood pressure, and then all of a sudden they've got renal failure, and they PIE within a year because they didn't know about it. And it's at this point it's pretty treatable. There are some cases of hypertension that cannot be treated. It's just like one of those things. But think of things like lifestyle consideration. Avoid smoking, avoid tobacco, weight reduction, avoid alcohol. Those are all modifiable things that you can do or teach your patient to help them weight loss. Teach them so that they can lower their blood pressure. But, okay. So on page 151, we have angiotensin converting enzyme inhibitors. Just write ACE. ACE. ACE inhibitors. So you've got ACEs, which pretty much all end in pril. Captopril, lisinopril, all the other prils there. ACEs usually end in pril. So our purpose, under purpose, the third bullet down there, the purpose is reduction in pathologic changes in the blood vessels and heart that result from the presence of angiotensin II and aldosterone. But ACEs prevent damage to the blood vessels and the heart. Simply put, prevent damage to blood vessels and heart. Okay? Complications, over on the other side of the page 151, complications, first dose orthostatic hypotension. Remember, before you give blood pressure meds, before you give diuretics, get your baseline. Find the pulse, find the blood pressure, get a baseline. But warn your clients about first dose orthostatic hypotension. ACEs are notorious for causing a dry cough. Unfortunately, ACEs also cause hyperkalemia. Another complication of ACEs, rash and, I'm not even going to try it, altered taste, changes in taste. That's a cool word. Yeah. Rash and altered taste. ACEs are kind of not notorious, but I have seen ACEs can cause what they call neutropenia, low white blood cells. So when your patients are on these ACEs, ACE inhibitors, lisinopril, captopril, it's very common that they have to have baseline lab work done, always. So you know what their WBC white count is. And then they may monitor them every couple weeks to months to determine if they're starting to have problems with neutropenia, low white blood count. And make sure, since they are at risk for having neutropenia, if they're having signs of infection, call the physician. Contact your provider. I always say physician, but there's lots of good providers out there. Okay, 152. Moving on, page 152, contraindications and precautions. Aha. Pregnancy risk category D during the second and third trimester related to potential for fetal injury. Down further on the page, nursing administration, advise, bullet number 1, 2, 3, 4, 5. Number 5, advise clients to notify the provider if they have a cough, rash, altered taste, or indications of infection. Just remember, ACEs are potassium sparing, so be careful, always know what your potassium level is. Other side of the page, on page 152, is angiotensin 2 receptor blockers. Just write ARBs. A lot of times, blood pressure medications, sorry, not too long. ACEs and ARBs. The ARB, the ARBs end in usually TAN, sartans. For the most part, you will see ACEs end in pril and ARBs end in sartan. If that helps you somehow remember it, please do. So angiotensin, the ARB, losartan, expected pharmacologic action under purpose is vasodilation. The veins don't constrict, they dilate, they get bigger. And then other purpose is excretion of sodium and water. So they help get rid of excess fluid. Interestingly enough, ARBs also delay progression of diabetic nephropathy. So you may see somebody who's got some early signs of kidney failure. They might put them on an ARB. It saves the kidney. So that was a highlighted item. Delay progression of diabetic nephropathy. Save the nephron, save the kidneys. Complications. For some reason, I highlighted this. The major difference between ACEs and ARBs is that ACEs usually cause the cough and the hyperkalemia, but ARBs usually don't cause the cough and hyperkalemia. So those are two defining factors for ACEs and ARBs. I can't tell you why right now. I'll tell you when you come back after break, but I wrote a big note down at the bottom of my page that says ACEs and ARBs are great for hypertension and diabetes therapy. Those prevention of diabetic nephropathy, diabetic retinopathy. That might have a lot to do with it. ACEs and ARBs, good treatments for hypertension and diabetes. Page 153, ARBs, ending in sartan, can cause hypotension. So we're going to tell our patients that are starting their ARBs, ACEs, to avoid alcohol, because the alcohol can actually potentiate, make that hypotension worse. Interactions on page 153. Besides interactions, I wrote ETOH, which is alcohol. Alcohol can potentiate your hypotensive reaction. So page 153, aldosterone antagonist, spironolactone. I don't have any helpful reminders on these because I guess they do end in ONE, but other than that, I can't tell you why. Aldosterone antagonists like spironolactone promote excretion of sodium and water, but retention of potassium. Remember, if you see a potassium of 5 and you're reaching for your spironolactone, don't do it. Find something else to give. Jump to page 154. Somehow I did not highlight anything under your direct renin inhibitors, but it doesn't mean that they're not important, so give it a look, see, but I didn't highlight anything there. Do highlight calcium channel blockers, and your prototypes here are nifedipine, verapamil, diltiazem. Expected pharmacologic action for nifedipine. It blocks the calcium channels in the blood vessels, leads to vasodilation of vascular smooth muscles and arteries, arterioles of the heart. I wrote myself a note down at the bottom of this page that says they use nifedipine a lot if they have concern for patients with heart failure. They do use nifedipine a lot if there is concern for heart failure.
If they have heart failure?
If there's concern, there's potential. Like if somebody has a big old MI and the heart is damaged and there's potential for heart failure, they might just put right on nifedipine right away. Yep. And they'll also use it during if somebody has heart failure. But if there's a risk, if they know it's coming their way, they might just put on it. Okay, so page 155, verapamil, diltiazem. These medications should slow the heart rate. All these different medications, either going to help control blood pressure, lower blood pressure, help get rid of excess fluid. Sometimes things like calcium channel blockers like verapamil, diltiazem, they just slow the heart rate. Because if your heart is beating so fast that it can't properly circulate, it's doing a whole lot of good. People get lightheaded, they get anxious. If you can slow the heart rate and make it more effective, then you're on the right track. So verapamil and diltiazem should slow your heart rate. Item number 2 there, blocking of calcium channels in the myocardium. SA node, AV node leads to decreased force of contraction, decreased heart rate, slowing of the rate of conduction through the AV node. Okay, therapeutic uses. I did like this tiny little chart here under therapeutic uses. When you're looking at cardiac dysrhythmias such as atrial fibrillation, you will see things like verapamil and diltiazem. So highlight your cardiac dysrhythmias like atrial fibrillation, and then take a little highlighter down the verapamil diltiazem row there. On page 155, under complications, nifedipine. Orthostatic hypotension. There's a theme there in some of these medications. Orthostatic hypotension and peripheral edema. So nursing considerations, we want to monitor the blood pressure, look for edema and daily weight. Instruct our clients to observe for swelling in the lower extremities and notify the provider if that occurs. Here I wrote it again. ETOH will make the risk of hypotension worse. Other side of the page, 155 on diltiazem. Nursing considerations. It's almost like deja vu. Monitor blood pressure, edema, and daily weight. Instruct the client to observe for swelling in the lower extremities. Notify the provider if it occurs. Also for things like verapamil and diltiazem, some of the complications, constipation. So make sure our clients are getting adequate fiber, adequate fluids. Verapamil and diltiazem, some of the complications can also be something called myalgia, muscle aching. Write down muscle aches, myalgia. Not listed, but I know it to be. It is myalgia. Also for verapamil and diltiazem, under suppression of cardiac function, bradycardia. So advise your clients to observe for suppression of cardiac function, meaning slow pulse. If they have a pulse less than 60, if they can't walk across the kitchen because they get short of breath and dizzy, they should hold their medication. So you're going to be doing a lot of patient teaching, how to check a pulse. If your pulse is less than 60, don't give the medication. Called the whole hospital setting. Down under contraindications, oh gosh, guys, I'm not going to make it for this one. Under contraindications and precautions, on page 155, verapamil is contraindicated in clients who have hypotension, heart block, digitoxicity, severe heart failure, and during lactation. We're going to finish interactions here for nifedipine on page 156, and then we're going to stop. Interactions for nifedipine, nifedipine beta blockers. When we get to that part, beta blockers like metoprolol can sometimes be given along with nifedipine, which actually helps decrease the reflex tachycardia. But be careful what you ask for, because metoprolol is supposed to slow and regulate heart rhythm. But if you give metoprolol, sometimes it's a little too much. Again, if the pulse is less than 60, hold the medication. For verapamil interactions, same thing another day. Verapamil is concurrent use of beta blockers, such as metoprolol, can lead to heart failure, AV block, and bradycardia, slowing of the heart rate. So as a last thing before I let you go here, and we'll meet back at noon in here. We'll be done by 2. Football players can't pick us up until 2. As a thing to think about before I let you go, medications affecting blood pressure. So what's a normal blood pressure? 120 over 80. Okay, so you got this patient who's been running 140s over 100s, 150s over 100s. And you go to the bedside and you're going to give them their, what? You're going to give them their lisinopril. And, oh, I'm just going to check the blood pressure here quick before we give this. And you get 88 over 50. What you going to do? Stop. Don't give it. Right? That's good nursing judgment. That's critical thinking.
How low is too low? Like, at what point?
I got to know their baseline, because somebody who's used to running 180 over 100 or 180 over 90, all of a sudden I get 100 over 60, which might be normal for some of you, but if you drop that much for that person, that might be fine.
So there's no like
There's no match. Know the baseline. The correct answer would be no the baseline. All right, see you guys back 12 noon. Thank you so much. Don't leave.